Let's start. Good evening, everyone, and a very warm namaste to everyone here from Dr. Taranjeet Kaur. I am your host and the curator as well as compiler of this interesting session called Making Sense of MaxFact TK Lives. Now, 2 years back when the pandemic was in the full stream and we had to continue with the education, this is when the difficult task of education was shifted on internet. And that is how the idea or the concept of TK Live came into existence. It's been approximately 2 years. And since then, TK Live has been moving slowly, gradually, and has been receiving fairly good amount of response from maxillofacial community from all over the world, for which I'm extremely grateful for. The main aim of TK Live has been to reduce preventable harm amongst our patients. And since preventable harm is one of the largest cause of disability, mortality, morbidity amongst patients, it is very important that we as maxillofacial surgeons, physicians, clinicians are well equipped through knowledge and understanding so that we can render excellent services to our patients. And for this reason, TK Live strives to invite experts from various specialities from all over the world so that we have an opportunity of interacting with all of them and learn the best practices and best understanding of the concepts through the experts directly. Now, that has been the main aim of TK Live in all these this duration that we have seen. Besides that, nothing is possible, no endeavor can be achieved alone, and hence I would like to pay my gratitude, my thanks to my co-associates who have been helping me all throughout tirelessly without expecting any kind of return or merit from my side. That is Dr. Yajas Kumar. I would like to pay my extreme gratitude to Dr. Yajas for helping me out through this not-for-profit endeavor, which would not get anybody any returns for that matter. Now, coming to the main thing, the format of the session is that after the introductions, the speaker will be talking for 40 to 45 minutes, and then the session will be taken over by the moderator of today's evening, which is Dr. Rajkumar. And the moderator will pick up the questions from the attendees, as well as we will have our own questions, which will be discussed in the next 30 to 35 minutes of the session. Now, during this time, I would like to really request all of you to please switch off your mobile phones, keep yourself muted, and your cameras off. Now, the reason is that this will unnecessarily consume the bandwidth and disrupt the proceedings of the session. And please put on your questions in the chat box. Now, I am not very comfortable doing multitasking, so my associate, Dr. Yajas Kumar, and of course, we have moderator, Dr. Rajkumar. These people will be helping us with question answer sessions as well as panel discussion in the end. Now, when it comes to Dr. Dorrit Nitzan,
yes,
you will have to. I'm stopping your screen sharing because I have to bring your introduction, ma'am. So,
excuse me, I cannot hear you.
Please, just wait. I have to. Professor Nitzan, I will give you the screen once the introduction is over. Is that fine?
Okay.
Yeah. So, even though you have, you have an amazing introduction of Professor Dorrit Nitzan, but one thing that I have realized is that Professor Dorrit Nitzan, being a researcher, is something that really fascinates me, because when what I understand about a researcher or a research scientist is someone who understands the unspoken unheard languages of phenomenon and patterns. Now, Dorrit Nitzan is somebody who is mastered this art of unspoken, unheard language of patterns and phenomenon of temporomandibular joint disorders. And it is through this understanding that Dr. Nitzan has achieved all that what she has in her long career of researches and a maxillofacial surgeon. So with these words, with these words, I would like to now proceed to this session, which will be moderated by my dear friend, Dr. Rajkumar from Bangalore.
Thank you.
So the guest speaker of today's evening, as you all know, is Professor Dorrit Nitzan, and it's an absolute honor and a privilege to host her today. Since her stay, Professor Nitzan is an emeritus professor who was born in Jerusalem on September 3rd, 1947. Professor Nitzan pursued her DMD and graduated from Hebrew University Hadassah School of Dental Medicine, Jerusalem, Israel in 1975, with specialization in oral and maxillofacial surgery. Professor Nitzan started her professional career in 1975-76 as a research associate at Anaerobic Laboratory, Virginia Polytechnic, USA, as a part of residency, and was a research associate at the Department of Periodontology, Harvard School of Dental Medicine, Boston, Mass, and at the Center, Boston, Massachusetts, US in 1976-78. Professor Nitzan was also a visiting professor at multiple universities like University of Florida, Gainesville, Florida, Columbia University, New York in US. She was a visiting professor at SDM College of Dental Sciences, Dharwad, India, and University of Rome, Italy. Since her stay in Gainesville, Florida, her main interest and contribution was in functioning and dysfunctioning of TMJ, with special attention to EM and biomechanical studies of synovial joint lubrication system, and the role of hyaluronic acid and phospholipids, which led to the development of long-acting biolubricant, which is now used in clinical studies. Professor Nitzan has also studied TMJ biomechanics, and her work has led to the description of anchored disc phenomenon, which then led to the development of techniques of TMJ arthrocentesis and other concerning studies related to TMJ disorders. Professor Nitzan emphasized the value of conservative protocol for ankylosis following condylar fractures, and has demonstrated the use of principles of close reduction in various conditions of loss of condylar vertical height, avoiding joint reconstruction. Currently, she is working on TMJ condylar hypoplasia. Besides this, Professor Nitzan has 5 beautiful children and 21 grandchildren. This session will be moderated by my dear friend, Dr. Rajkumar K, who is a wing commander and a classified specialist in oral and maxillofacial surgery department at Air Force Institute of Dental Sciences, Bangalore. Dr. Rajkumar has completed his Bachelor of Dental Surgery from Government Dental College, Bangalore 2000, and graduated with Masters in Maxillofacial Surgery from Armed Forces of Medical College, Pune 2010. Dr. Rajkumar has completed his PhD in TMJ surgery from Meenakshi University, Chennai in 2022, which is very recently, and is trained in an attachment in TMJ surgery from Melbourne, Australia. Dr. Rajkumar has special interest in TMJ surgery and facial trauma surgery, along with orthodontic surgery and reconstructive surgery. Dr. Rajkumar has been awarded with Vice Chief of Army Staff Commendation Card India, and has won 3rd Best Paper Award for published article in Indian Journal of Oral and Maxillofacial Surgery. And with this, I would like to now open us. I would now like to invite Professor Dorrit Nitzan for her presentation. The evening, the dais is all yours, ma'am. But thank you. You can now share. Professor Nitzan, you can now share.
I just wonder, what was the paper about?
Ma'am, it was about disc repositioning, ma'am. This paper was about TMJ and disc repositioning using an
About
orthodontic
what?
disc
Can you
repositioning.
send me the paper?
I will send it to you, ma'am. I will send it
Okay,
to you.
good.
It's a procedure I've stopped doing. You know, I don't do many disc repositionings anymore.
Ah,
So,
okay.
yeah. So
See?
I mean disc repositionings. I'll send it to you, ma'am.
Please. Just a minute. Okay. Okay. So everyone knows the topic. I would like to, if they need any questions, shall we do it at the end, or I can stop in the middle?
No, we'll take it at the end, ma'am. You finish your lecture.
At the end, okay. So the topic will be arthrocentesis, and first of all, we will talk about what we are doing, what is it, what is the procedure, but much more important is why does it work and when shall we do it? Because when we talk about such a simple procedure, it's really like, I mean, what can it do after all? So I would like to start with this short film. You see here, this is a short video of the temporomandibular joint in a cadaver lab in Vienna, that actually it was about 90 years old lady. And when you look at the function, you see that the function is actually perfect. And as I wrote down, this is 788, 400 hours. So when we look at such a durable joint, we ask ourselves, how can it be such a complex architecture and a joint that functions around the clock at 24 hours a day, and it is located in such a strategic location? How come it can function sometimes without any problem for so many thousands of hours? So first of all, this is my main philosophy in my area, which this joint calls for respect and minimal intervention. And I think nowadays I see tremendous numbers of unnecessary procedures, which are actually behaving a little bit like engineers or carpenters and not like biologists. We have to remember that we deal not with a furniture, but with a biological element. So first of all, I will talk shortly about the endurance of the joint, and then the procedure, how does it work, mode of action, and then we will talk about how does arthrocentesis work for joint pain and limited mouth opening. And my last question will be the contribution of imaging to our everyday work. So endurance, we talked already that this joint really has a very long survival. And the main three factors that make it survive is its efficient lubrication, second, shock absorber, third, remodeling potential. Let's see very shortly about each of them. Any machine needs lubrication. So if we look at this short film, you see how the yellow stuff is important. Yellow is the lubrication, and without it, the system cannot work. But when we talk about cars, we see that there are so many potential oils. When you go into shop in the United States, endless number of oils for the car. But there is actually not any product in the market available, like to act as an oil for the synovial joints. In the synovial joints, the main lubricant, synovial fluid components are hyaluronic acid and lubricin, which include these three products, of which, to my opinion, phospholipids are the most important. So, and also we have we published 2009 liposome that is a very effective biolubricant for friction reduction in human synovial joint. It is now in clinical studies, actually in India. And still, you know, so many years, already 13 years, and I wonder how many years still we have to check this product. The second factor is shock absorber. You know, everyone knows that cars has shock absorber, and the car needs it for, you know, really take over long ways. And we see that the disc, the bones, spongy bones, and synovial fluid, and the subchondral bone are all are helping the joint in attenuation of load. And that's why when we have such a joint, we really have to understand that we have to be careful. But such a marble bone cannot protect the cartilage. The third factor is remodeling potential, which exists only in the temporomandibular joint, maybe, I think only. When you look at long bone, we have the growth plate here that simply disappear after growth period. In the temporomandibular joint, we have the proliferative layer, which is actually stem cells that are responsible for the joint, for the mandible growth, but also for remodeling. So when we see this panoramic, you can see one condyle, and we see the other condyle, huge. This is condylar hyperplasia. The reason we have condylar hyperplasia only in the temporomandibular joint is like this. You can see the condyle from above. This is the normal area, and this is a pathological area. It's a small area that the potential walk up and grow, and it caused tremendous asymmetry to the face. So we understand that this characteristic of the stem cells, of the proliferative layer, is very good for remodeling, but it can also be pathological. And therefore, when we talk about other joint, hip joint, hip joint, knee joint, feet, hands, degenerative joint disease increase with age. However, in the temporomandibular joint, in the study we have done, you see the bell shape. The bell shape that we don't see many patients in the older decade. It's mostly right there in the middle. And that's because it is not a joint that gets old. It's a joint that can be overloaded, but mostly in the years of overloading, like I am already in this stage. I have no problem in my temporomandibular joints. So, but if we talk about these three factors, how after all we see dysfunction? Okay, so what keeps the joint functioning is the controlled loading, continuous function, and stable occlusion. three factors that we have to make sure exist if we want the joint to survive. Okay? We need control loading, we need continuous function, we need stable occlusion. Now, if we have overloading or immobilization of the joint or unstable occlusion, immediately the whole system is compromised. So when we have a patient, and this is the first stage for dysfunction, overload or immobilization or unstable occlusion, the combination will lead to dysfunction. That's why every patient we have to really use like a puzzle. We have to see where is the overloading, why is immobilization, and look at the occlusion if there is a problem. So we have three keys: control loading, rehabilitation, function, and watch the occlusion. Three factors that we have to make sure. Now we into the procedure. In the 90s, I have done arthroscopy in the United States and others, and you see that the results were very good, although it was simple arthroscopic lavage and lysis. The results were really quite good for closed lock. When I came home to Israel, I didn't have an arthroscope, and I said, logically, I can do lavage with any needle. So I took simple 18 gauge needle, and now we do it like that. We use prophylaxis, careful preparation, local anesthesia. Remember, local, not general, no need for general. Using 18 gauge needle because we want the needle to be rigid and not flexible. We want the needle that we have control on the needle when we enter the joint. And we use only 1 ml saline syringe. The reason for that is that we look for the space of the upper joint space. If we use 10 ml, then we always introduce much fluid into the joint, and that's bad. We have to use a little bit, and then the patient will never be swollen. Only 1 ml syringe, and if we are inside or not inside, we don't harm the joint, we don't cause any swelling. Then, when we are in the joint, we can inject 2 to 3 ml saline and introduce a second needle, and then flush the joint with whatever, we don't want to discuss it now, 100 to 300 or 400 ml under controlled pressure. We have to make sure that any fluid that comes in comes out. Otherwise, again, the patient will be swollen, and we don't want that. We follow the direction of McCain, but this is only the drawing, but we have to use palpation to make sure that we know where we are located. This is in cadaver, first needle in the upper compartment, in the fossa region, second in front of the eminence, but this is not really rigid rule. If this is a joint, we can enter here and flush the joint, and then easily introduce the other needle, let the fluid come out. Usually the needle comes in from in front of the eminence. We can also, if we have a problem, we can use 2 needles in the same spot. If a patient is anxious and we want to local anesthetize only this region, we introduce the 2 needles to the same spot. Or remember that always when we introduce the needle, we ask the patient to move the jaw contralaterally. And then the space is really open and you can palpate and enter the upper compartment very easily. This is a location that we can enter, which is very easy to enter. So this is just a tip, but it is not the really common way to do. I do it many times. As what to inject into, I don't want to discuss the topic, what would we inject into the joint, because it is a topic by itself. Now, mode of action. When we push fluid into the joint, we separate the adherent surfaces. We wash away a fusion, inflammatory, blood, and degraded product. And we eliminate joint effusion and facilitate aspiration and introduction of medication. When we look at that, we see, אפשר להדליק את ה-air condition? מודלק? Because when we look only at arthrocentesis as a procedure, and we look at the role, I mean, our principle of treatment, control loading, rehabilitate function, and watch the occlusion, and then look at each, I'm sorry, the arrow moved, separate the surface, it allows movement, washes away whatever, it reduces the pain, and it sometimes solves malocclusion that is caused by a fusion. Okay, and also elimination of effusion, it reduces the intra-articular pressure, it reduces pain, and again, can solve a problem of malocclusion. It allows aspiration for diagnosis and then introduction of medication, which we don't discuss now, but this can really reduce pain and enable movement. In other words, arthrocentesis by itself is very, very efficient when we talk about our goals. But never, I want the audience to make sure, how many people are in the audience, please? Do you know?
I think
About?
25, 30 or so, I think.
Excuse me?
I think around 30 or so, I think, currently.
Okay, because I want everyone to know that you never do arthrocentesis without complementing it by one, control of joint loading by appliance that reduces the load on the joint, and diet, and make sure that the patient chew on the same side of the pain. This is the lowest loading spot. Then physiotherapy should always complement arthrocentesis, and then elimination of occlusal hazard. For example, posterior bite collapse or premature contact. We have to diagnose the weak point in each patient and make sure that arthrocentesis is not done by itself. Okay, control loading, we've done a study in the 90s. You can see here the patient. We have a needle in the joint, and here a machine that measures the intra-articular pressure. You see here the ear, and here the recording. And what we have found that when we use an appliance like that, this is the normal patient. This is the vector of the occlusal surface forces. This is the vector of the muscles. Now we know, according to the rule of level 3 system, when we take the resistant arm and make it shorter, can you see? By using an appliance that makes sure that the occlusal forces will be backward, can you see that it is not, the vector is not here, it is here. When we use a simple flat appliance, you can see here the vector, and here you see how shorter it is. And what we have found, that we reduce the intra-articular pressure by 80% when we use this appliance. So this is a good simple appliance that will complement arthrocentesis. We want, like any joint, when we operate on the elbow, for example, then we ask the patient not to function with the elbow for a period, but we cannot ask the patient to stop clenching. That's why we have to use at night an appliance that reduce the load on the joint. Rehabilitate function. We also measure the pressure during function. And what we see is that during clenching and opening, we have this recording up and down, positive pressure, negative pressure, positive, negative. And in other words, we have function is like a pump that is responsible on the joint nutrition, waste removal, lubrication, and in children, mandibular growth. We know that when we don't have function, the mandible will not grow. Even if we have an extra articular cause that stops the joints from functioning, and the joint is normal, the joint will not grow. So if the joint doesn't function, it will not grow when we talk about children. And here is simple, you know, the physiotherapy. As to occlusion, we have to make sure. For example, this patient came with severe pain, as you see. And here we see loading test, you know, loading test with a paddle here, right? And she has localized pain in the joint. When we look intraorally, you can see she underwent implants right here, but they didn't replace the teeth, but by support to the occlusion. And immediately she developed this severe pain in her left tympanomandibular joint. Now, I will never do arthrocentesis without an appliance that will support the joint on the right side. This is what I meant, that we have to make sure that we have stable occlusion. Just 1 second. כן? ביי מותיק. אוקיי, בסדר, נמצא אותך. Arthrocentesis, we'll talk about only 3 factors. Joint pain, joint limited mouth opening, and malocclusion originate in the joint. Joint pain, first of all, we have to talk about patient main complaints is like pain, noise, limited mouth opening, malocclusion, asymmetry. These are the main complaints that we hear about when the patients come in. Now remember, we have very carefully check every patient and feel it like a puzzle, that you take each piece and make sure that you have a complete picture. Because if you take only 2 pieces, you have the wrong picture sometimes. If you take maybe all but 1, you may do mistakes. If you want, sometimes we can talk about simple examination to have the right diagnosis in the joint. So this is the first rule, have the right diagnosis. But if we have joint pain that is localized, like in this patient, then we know already that arthrocentesis is excellent logically, no research. If you separate and you washes away and you eliminate a fusion and you can inject medication, you know that this procedure will help the pain of the patient. But also there was a study done by Eliav that is now in the United States, but he published in Pain that he could see really that there was increase in the pain threshold of the auriculotemporal nerve after arthrocentesis. This is the pain threshold before arthrocentesis, and this is after. So objectively, it is excellent for joint pain, but I'm talking about joint pain, not about muscle pain. And here, simple study we done on anchor disc phenomena reduction in pain, osteoarthritis, disc distillation without reduction, some reduction in pain, and in osteoarthritis. We have reduction in pain when we use arthrocentesis. Now about limited motion. This is an interesting topic because we have many reasons for limited mouth opening. The first one is very common, is closed lock. The second one is osteoarthritis, right? The third one is that I wanted to talk about is inflammatory disease, because it is a very important topic. Those patients with rheumatoid arthritis and FNM and psoriatic arthritis and ankylosing spondylitis, this patient, we have to make sure very carefully, very intuitively, you diagnose that they have joint pain. But actually this patient most of the time will not have joint pain. And if they have acute pain, arthrocentesis is excellent for them. Okay, closed lock. There are two types of closed lock. In a study we've done in 91, we've separated two types of closed lock. The one is moderate limited mouth opening caused by disc displacement without reduction. And the second one is severe limited mouth opening caused by ADP, which is anchored disc phenomenon. Let's start with the first one. We know that this is disc displacement without reduction. Limited mouth opening is caused by obstruction of the disc itself. But this is, not much. The limitation is not severe. The limitation is only partial. And by physiotherapy, we can really improve this limitation. And arthrocentesis will not bring back this disc to the right location. And we always have to ask ourselves, is it important for the disc to be in the right location? Not always, not at all. They will have 30, 35 millimeter opening. So what we found that when we did arthrocentesis, we could increase the mouth opening in about 5 millimeter. There is a difference between 32 to 37. And those patients can be happy enough with this improvement. And then physiotherapy will further improve. So limited mouth opening in cases of this displacement without reduction, I don't believe in most cases need surgery. And pain also reduces, not perfect, from 8 to 5, which is not perfect. But we can continue with conservative means, or sometimes we do need surgery. So arthrocentesis for this displacement without reduction will reduce localized pain, not 100%, and it will improve slightly maximal mouth opening. But in many cases, in my experience, it was sufficient to avoid surgical intervention. ADP is another phenomenon. This girl is 15, and she came with sudden limited mouth opening with deviation to the right, 22 millimeters after 8 months that she was trying physiotherapy. By the fact that she moves to the right means that she has some limitation on the right joint. Her movement to the right, excellent. Her movement to the left, limited. And what we see in X-ray is this, look here, closed position, normal joint with normal space. However, in opening, we have very limited rotation of the condyle, and that's all. So we understand that there is limitation, and we want to know why. The MRI of these cases will look like this. Just a minute. You see that the condyle has some slight limited rotation. After arthrocentesis for this patient, we see immediate improvement. Can you see that? An immediate contralateral movement, an immediate, of course, ipsilateral end protrusion. What happened there? What happened in this acute condition that was there for 8 months, and you can solve it in 5 minutes? So I was asked by you, like, what was the initiation of the research? I was extremely interested. What happened here? And I was not able to explain. I know that there is a problem with lubrication, but I didn't know anything about lubrication. So one time a patient came with her father, and the father asked me, what does a girl have? And I told him, I don't know what she has. I only know that I can solve it, but I don't know why. I'm looking for a person that is expert in joint lubrication. And he said, you know, I am world expert. And from this point, we started to work together. And we end up that, you see this limitation, after arthrocentesis, immediate improvement. And we understand that if we look, this is a situation. Hello. Sorry, 1 second. שלום מוטי. מסכנה. תלבשי מיד בגד ים ותלכי. תלבשי מיד בגד ים ותרדי לים. לא, אני נשימה. יש לה זמן. Okay. When you see, my daughter came. When you look at this film, this is a normal movement with lubrication. When the patient clench in 1 minute, overloading disrupt lubrication and the disc is stuck. Now the condyle only can rotate under the disc. So what shall we do? What happened here? And this professor at Sion helped me understand that what we have is exactly what happened in this glass. When I hold the glass, when it's dry, no problem. But when you have a few drops between the smooth glass to the plate, it will be stuck together. And when we put it under the water, it will separate immediately. And what we have, these are adherence forces between the fossa and the neck disc. And here is an article of Etzion and myself that we publish on this phenomena. We have to remember our physiotherapy is not absolutely recommended before arthrocentesis. Always start with arthrocentesis and only then appliance and physiotherapy. Osteoarthritis is another topic. You remember that we talk about the special potential of the temporomandibular joint and the fact that we have these bell shape. And we actually approach osteoarthritis as an adaptation, joint adaptation or failure to adapt. As long as you adapt, you can have asymptomatic osteoarthritis and you don't even know you have. But when you fail to adapt, then you can fall into this category of symptomatic osteoarthritis. The question is, what shall we do now? Do we want a beautiful joint or do we want a functioning joint? So in my eyes, since we have remodeling potential, as I said before, all we want is to look at this joint adaptation, failure to adapt, symptomatic. We want to change the direction. Just a minute. As long as we have failure to adapt, then we have joint pain, limitation, joint noises, occlusal changes, many types. We can talk about it other time. And imaging changes. It can be only one of them or all together. So the joint is really miserable. We want to do, just a minute. Oh, I missed a slide, I'm sorry. Our purpose is, okay, I'm sorry. So when there is a failure to adapt, then we have joint pain, we have severely limited mouth opening with collapse of the occlusion. We may have open bite like in this girl. And our treatment approach is only that. We want to bring the joint from the position of failure to adapt to adaptation. And by that, we can bring symptomatic osteoarthritis to asymptomatic. And we found it extremely, extremely wise, because in a minute you will see. So when you look at this car, all we want is to bring this car back to the road, let it start driving. This woman has severely limited mouth opening, severe pain, severe changes in her movement, and severe appearance of her joint, severe osteoarthritis. You know, in the world nowadays, what they do, they take it and put joint replacement. I don't believe in that in most cases. So we want diagnosis of the risk factor, remember, control of loading, rehabilitate movement, elimination of occlusal hazard, as Mahon said in his article. First, we put the appliance to unload the joint. We do arthrocentesis, and look at this lady. She opens immediately perfect. And here she is, the contralateral movement are perfect. And after 8 months, she looks like that. And she never had any symptoms later on. And remember carefully, the joint didn't change. It still looks like that. So we don't treat the X-ray, we treat the patient. 81% of the symptomatic patients with osteoarthritis respond to arthrocentesis. In the rest, 19% severe, you know, arthrocentesis act as a diagnostic tool, and we know 20% of the patient we may have to operate. But this is a case that we know that we have to operate and that there is no conservative way to take care of it. Here is a study that we have done reduction of pain from 7 to 2.3, dysfunction from 7 to 2.2, improvement subjective was from the patient point of view 8.2, maximal mouth opening increase in the patient we've treated from 26 to 39 and so on. So we have, it is not perfect, but it is good enough for the patient to go on without complication of any extra surgical intervention. Imaging and prognosis. When we look at, we ask the question, is there any correlation between the way the joint looks and the signs and symptoms? Or is there any correlation between the imaging and the outcome of arthrocentesis? In our study, we found like this, look at the terrible looking joints. There is no significant correlation between the severity of the CT scan image and the clinical signs and symptoms and the response to arthrocentesis. So when a patient comes in and you look at his CT, you cannot tell him, oh, you have nice looking CT, it will work very well, or it is bad looking, bad looking CT scan, we are going to fail. Not at all. We simply do not know. We have to do arthrocentesis, and only then we know if we were successful or not. Imaging cannot be used as prognostic tool. Arthrocentesis, when failed, become a diagnostic tool that leads safely to surgical intervention. Conclusion is we have a procedure that is simple, non-surgical, cheap, harmless, can be done under local anesthesia, modest skills, minimal equipment needed, and must be complemented. Efficient, especially for joint pain, open lock, which I didn't talk about, and limited mouth opening. Its efficiency is unpredictable. When failed, it acts as a diagnostic tool and has had to inquire Wilkes classification. If you want, I can talk about this classification. I'm not sure you use it, so I didn't want to mention it, but if you want, we can. I don't like this classification. I think it is wrong. So now I would like to thank all the department, all my colleagues, and here is another patient of mine. Thank you very much.
Thank you so much, Dr. Dorrit. It was an amazing lecture, very informative, and a deep insight into arthrocentesis. Dr. Rajkumar, should we start the question answer session?
Sure, ma'am. Thank you, Professor Dorrit, for a wonderful session and wonderful lecture on arthrocentesis. So very clear what you said. But yeah, it was always so nice interacting with you. Just coming from the lecture and what you said, ma'am, we know that arthrocentesis definitely works very well in anchor disc phenomenon. But if you look at other conditions like a chronic non-reducing disc displacement or osteoarthritis of the TNJ, what do you think does it have a definitive role, or should we start with physiotherapy and then go for arthrocentesis? Like in a chronic non-reducing displacement where patients having...
Oh, you have to speak more slowly. Yeah. You have to speak more slowly.
Okay. Am I audible, ma'am? Yeah. What I'm saying is, from the lecture that you've given, now we are sure that arthrocentesis works very well in anchor disc phenomenon. But in case of in case of non-reducing displacement, chronic non-reducing disc displacements, where the patient is having limited opening for a long time, so do you recommend arthrocentesis as a first line of treatment? So,
yes. Okay. I always think it is in the first line.
Yeah. Or do you think we should go ahead with physiotherapy and non-surgical management before we go for arthrocentesis?
It depends. If you have really localized pain in the joint,
yeah,
then I use the appliance, which is an unloading appliance at night. Okay. And this helps. The one I talked about, did you hear?
Yes, I have received that from your mail earlier. to
So
increase the
I use
resistance.
this appliance, and if this doesn't work, then I'm gentle with painful joints. It depends. Many times I decide to do first arthrocentesis and then physiotherapy. If you have a strong muscular component, then of course you have to do physiotherapy. But if the main component is the joint, then I prefer an appliance and arthrocentesis if the appliance was not sufficient.
And one of your other articles says that, in terms of arthritis, arthrocentesis works well in better in inflammatory arthritis like rheumatoid arthritis and other kind of inflammatory arthritis. Comparatively, the effect is lesser in osteoarthritis. This is from the article you written in 2006. So what are your comments on that? Do you think...
Wait, more slowly.
Yeah. I think this is a 2006 article which you written in the oral maxillofacial surgery clinics, where you say the effects of arthrocentesis are better in inflammatory arthritis compared to osteoarthritis. So what is the current guideline and what is your thought on that, ma'am?
You mean about other inflammatory diseases?
Yeah.
High
I've never... What?
High inflammatory diseases.
What?
I think osteoarthritis is a low inflammatory disease.
Excuse me, I can't hear you.
I said osteoarthritis is a low inflammatory disease. We are looking at high inflammatory diseases.
Okay. Now I hear you.
That's what he was trying to say.
I never published it, but I have excellent experience with children and adults, with inflammatory, with all those diseases that are in rheumatoid arthritis, psoriatic, I'm sorry I didn't talk about it, psoriatic arthritis, even ankylosing spondylitis, all these are very responding pain, and when you give them support by an appliance, an arthrocentesis, I really see very good results. But there is a limit. I'm sorry. There is a limit but in those cases, I'm very careful not to treat too much, because if you enter a diseased joint, remember that you harm this joint. So I try always in those inflammatory cases to be very, very gentle. And I feel that it is really functions very well. And also, you have to remember that even in osteoarthritis, if you intervene, then you have the disease itself, and then you have the intervention, and the joint has to cope with both. So you have to I try to be as gentle as possible with diseased joints. And so this is actually my approach. And remember, the most important things which I found is the right diagnosis. Because if the patient comes in the wheelchair with rheumatoid, I have many patients, I can give you the samples, I have slides. They come with wheelchair, with rheumatoid arthritis, with all the disease all over. Immediately you imagine that also this joint is, but no. 80% of these patients have muscular pain.
Yes.
You have to do that. And that's why I don't trust the papers the many papers that are dealing with rheumatoid arthritis in the temporomandibular joint. Rarely these diseases affect the temporomandibular joint. And if it affects, I can give you samples of really excellent results. I mean, you can many times you cannot avoid the chin retruded and the open bite and things like that, but you can control the pain and you can control function. And then later on, You can deal with orthodontic surgery, which is predictable. Joint replacement is not predictable, really. Orthodontic surgery is predictable. You know that if you are talented, you give him good surgery and he is good forever. And I can give you samples of that. So I always prefer to give a predictable treatment that I can give the patient good life and not an anxiety for what is going to happen in 10, 15 years, and unless it is required. Okay?
Okay.
Yeah,
Did I
ma'am.
answer you?
Yes, that's a fantastic explanation, ma'am. So, most of the TMJ case I see in my practice, they come, when there's localized joint pain, they don't have any clicking or so. So it's probably a synovial inflammation that is there.
And we can really talk sometimes about the diagnosis, because also 80% of the patient comes in with joint pain. It is actually muscle pain, because they may have clicking and they say, I have clicking and painful joint. But the pain comes from the muscles and the noise comes from the joint, and they don't separate. But we have to separate and explain them. You have noise and you have pain. We have to take care separately. First of all, pain, and then we'll see how we deal with the noise. And then many times they say, okay, I cannot take it, and then you can operate on them. But many times they say, oh, it's okay without pain.
So, Professor Nitzan, you are trying to say that the pain is generally from the muscle, you don't have intra-articular pain?
You have, each patient is a different puzzle.
Yes. There are a lot of overlaps, I agree.
Overlaps, yes, but you have to make sure. Many times the pain, do you know what loading test is?
Mahan's test. We are talking about Mahan's test.
I don't, what?
Mahan's test.
Ma'am, it was
the ice cream stick on the opposite side.
Yeah.
Stick on the opposite side, yes.
Yeah, this is important, because when you touch here, you actually touch the masseter, the lateral pterygoid, and the joint. So this doesn't mean anything. You understand? It means something, but it is not enough. And also you can tell the patient open, and the patient says, where is the pain? Tell me. And he will point here.
Yes.
So this is a masseter. This is a posterior part of the masseter. This is a so it is everything is very near to each other.
Okay.
But don't you think that synovitis is probably the most common condition that we encounter in TMJ practice?
You see, so you have to wash it and use an appliance. It's very, like you have synovitis, I have in my knee.
Yeah.
You know that I can stop running, right?
Yeah.
But here I cannot stop running with my jaws, so I put an appliance.
True.
Simple, it's very cheap. It's the cheapest one.
True. And another thing, ma'am, is many of the patients come with complaint of clicking. You have mentioned in some of your papers that clicking does reduce with arthrocentesis. So what is your view on that?
Arthrocentesis may soften the click.
Yeah.
But if a patient suffers from the clicking, and then you have to operate on him. But remember, it may come back because the reason is still there.
Yeah.
You don't treat the cause, you treat the result.
Yeah. True.
Of overloading. So the patient should, be aware.
Yeah, some of the papers which are written, I've seen that it works well in the intermittent clicking, and compared to a completely
intermittent clicking responds very well to arthrocentesis.
Arthrocentesis. That's true.
Intermittent, not constant.
Yeah, not a completely dislocated disc.
Yeah.
Completely dislocated disc. Ma'am, any question from your side, Taranjit, ma'am?
Yeah, I wanted to know the role of estrogen in TMDs. what are your thoughts on role of estrogen as a hormone in TMDs?
What?
Role of estrogen hormone in TMDs. Do you think estrogen has a role to play in causation of temporomandibular joint disorders in women?
I couldn't follow. I can't hear. Can you say the question?
Ma'am, we have a hormone called estrogen.
Estrogen.
Estrogen. No, I don't believe in it. There are many studies that show that.
Yeah.
But I'm not expert in that.
Okay.
Yes, because there are a lot of people who say that estrogen has a role to play, and that is the reason why women of a certain age group from this to this land up having high predisposition to TMDs. So if estrogen...
First of all, lady, I don't like the term TMD. It has no meaning.
All right.
TMD is, like you say, the whole world. You have to be specific. Do you talk about the joint? Do you talk about the muscles? Do you put about what? So TMD is the wrong term. Then I don't know. I've heard many articles saying that hormones do not have any effect, but actually I don't know. I don't know.
Some of the studies have shown that there are estrogen receptors within the temporomandibular joint, and when the estrogen levels are high, there is an increase in pain modulation that is created by this estrogen receptors. So, as you said, from the initial diagnosis for TMJ, it is actually following a Bell's curve. So probably, the question relating to this was, does during the time when patients menstruating or before the menopause, most of these patients are women, and most of the symptoms are from the age of 15 to 45 or 50, and after that the patient become asymptomatic. So that was the...
So how do you explain this? If the estrogen has a minimal role or doubtful role, then how do we explain the incidence of this condition in women of menstruation age?
Actually now, after the corona, I have many men patients, many male.
Okay.
Many male. But I simply never studied this aspect. I don't know why, it never attracted me. So I'm sorry that I cannot help you with that.
All right, no worries.
I'm sorry.
Ma'am, you have written articles regarding subboundary lubrication and the role of phospholipids and the effect of hyaluronic acid on the protection of phospholipids from phospholipase A2. So do you think that extrinsic application of hyaluronic acid or any other kind of lubricants would help maintain the phospholipid layer or help regenerate the phospholipid layer and improve the subboundary or the boundary lubrication?
I'll tell you, I see that you know that. I'll tell you, if you have inflamed joint,
yeah,
and you inject hyaluronic acid, it will be degraded immediately.
Correct, true.
So I prefer simply to use, as I said, appliance, protect, reduce the load, wash the joint, and then I keep the appliance for 24 hours in the mouth, and the lubrication system rehabilitate itself. There is no need in injection. You understand? Because we talk mostly about young people and they rehabilitate by themselves. And injection of, it's very expensive. Why? Why should I inject it?
Yeah.
I don't find, and also the literature is very debatable about hyaluronic acid.
True. That's right. Ma'am, any question from your side, Taranjit ma'am?
There was a question by Dr. Prithvi. He wanted to know about a difference between soft splint and hard splint, and what kind of orthotics does Professor Nitzan prefer for the patients after arthrocentesis?
Excuse me?
The splints, the oral appliance that you advise your patients after arthrocentesis, what kind of appliance do you advise? Soft appliance or a hard appliance? Is there any specific?
I did show you what appliance
Flat appliance. I think you showed a flat appliance, yeah.
I use hard.
You hard. hard, flat appliance. Okay.
Hard, yes. Because if you use soft, you may start with muscular clenching on that. That's what I feel. So I prefer hard.
Ma'am,
One
sorry,
more
can I?
question Dr. Prithvi had. He wanted to know the difference between how to differentiate between articular pain and muscular pain. Is there any particular technique you have, a diagnostic test?
Again? I couldn't follow you.
Ma'am,
Articular pain and the muscular pain, how do you differentiate clinically? Do you have any technique through which you can make out the difference?
It's a little bit hard to explain in 1 minute.
Okay.
We have to separate, to really talk about clinical examination.
Okay. All right.
I think it's better.
yeah, I would just like to share
But
my
like
view.
loading test and palpation and as I told you, it's a puzzle. It's not one, they're complementary. The pieces of information complement one another.
Okay.
Ma'am, I would just like to share my the way I do my splints. So I initially make a thermoplastic splint because I feel the fit is better when you make a soft splint initially, and then I take a bite registration in that position, where the best occlusion you get with a thermoplastic splint, and then I overlay the hard acrylic on that, so that the fit, the fit is better. At the same time, the loading of the joint is decreased.
So it's more comfortable.
Yeah, it's more, the fit is more comfortable, and at the same time you have a hard splint, hard occlusal surface which prevents the joint loading.
If you can send me, I will be happy to see what exactly.
I will send it. It's a very simple appliance to make.
Show me, because it's difficult to understand without seeing. So I'll be happy.
Yeah, I will send it to you.
Okay.
Yeah, I will send it to you. I will send it to you.
Professor Nitzan, I have a couple of more questions. Does arthrocentesis have any impact on deviation also? Does it improve deviation as well in your experience?
Deviation in?
Like in case of anterior disc displacement without reduction, there is a deviation of the mandible on the same side. Does it have any impact on that as well? Does it improve that besides the pain?
No, you see, it will improve the range of motion, not completely. So you will still have deviation in opening.
Okay.
Because it doesn't change the location of the disc.
Okay.
So you still have some limitation. And if you have the deviation to begin with, it will still be there. You understand?
Yes, definitely. We also wanted to know about your views on Wilks classification, which you said that you have skipped in your.
Oh, this is
that you are not in favor of Wilks classification?
This is a long story now. I think we should give it a separate time, because I want to be very accurate, and I want you to understand why he was my friend many years ago. But with the years, I've learned that his classification is wrong. So, and I think it's not only wrong, but it's really misleading the young doctors, because they come and say, Wilks 3, Wilks 4, and they go into the operating room.
Yes.
But none of them is right. So what's going on there? How do they judge? It's like a tool, misleading tool, which I don't like, really. So another classification has to be.
Ma'am, so do you have
classification? We must have Professor Nitzan's classification.
No, we really have to do it.
Yes.
Do you have any subjective pain score you see before clinically before you take the patient up for arthrocentesis? Do you use like a visual analog scale? Do you use any subjective pain score to assess the amount of pain?
Yeah, I used yes. We have a questionnaire.
Yeah. Okay. Is it like the SF-36 questionnaire, or it's like a different questionnaire which you have?
Yeah, I don't know. It's our questionnaire that we developed.
Okay.
I can
Okay.
send you, maybe I have it in English.
I would
Yeah.
like to have it too, ma'am. I would also like
Okay,
to
so
have it.
I think I have it in English.
Yes.
Yeah. Correct.
So we
And
can,
regarding the procedure per se, ma'am, the recommended lavage is around 200 to 300 ml. So do you lavage the joint with around 200 to 300 ml, or it's less or more? What is the amount of lavage you do? Amount
about 200, 1 to 200.
200 ml. Okay.
Although the literature speak about that you have to do 400 to eliminate all the proteins.
Correct.
But I don't feel it's important. I feel when the fluid go very easily, at first it's sometimes more difficult, and then when it flows and it's clean when it comes out, it's enough for me.
Yeah. So do you always follow this 10-2 and 10-10 markings, or do you think there are other modifications?
This I do for, but then palpation. And
Okay.
one is
Yeah.
palpation. Second
Yeah.
is to ask the patient to move his jaw contralaterally.
Correct.
And then
Correct.
you can palpate, and it goes together.
Yeah.
The lines with the palpation.
True.
And then I feel very comfortable.
No, because there are different markings given by different people. There's many studies that have come from Turkey, which is given this point C and point D also, which are like,
I don't like this nonsense, because I mean, you're a human being, you can palpate. And
It's true. That's right.
There
Ma'am.
are
That's
two
right.
questions, Dr. Rajkumar. Can I ask them?
Yeah, sure.
So the one
Yeah.
question is, your favored solution is always Ringer's lactate for arthrocentesis, or what are the solutions you recommend?
What?
The solutions for arthrocentesis, does it always have to be only Ringer's lactate?
No, saline.
Saline.
Yeah, not important because it's mechanical.
Okay. And there's another question on condylar hyperplasia. Does it affect the disc over a period of time?
What? Does
condylar hyperplasia affect the disc, articular disc, over a period of time?
Oh, this is a big topic. I'll be happy to talk about.
Yes, I know. We would be happy to hear also about it. Because that's
No, this is really a long, very interesting topic. We can talk about it some other time. Okay.
Yes. Professor Nitzan, one last question from my side. How has your understanding of arthrocentesis evolved in all these years? One, and two, what are the complications that we should be aware of when
What is the first question?
in all these years of your understanding and the technique of arthrocentesis, how has it evolved? What are the things that you have seen changing? Are there any changes in your thought process that you have come across?
The most important thing is that you can be very simple. As I showed you, you can, when you, just this, for example, that you move the jaw contralaterally and you palpate, and you can easily enter the joint, and you can put the second needle parallel to the first one. You don't have to do all the complicate, like in arthroscopy. You can put the needles where it's comfortable for you to put it. You understand?
But the role of Professor Nitzan, but the role of arthrocentesis in diagnosis is very, very unclear as of now. Don't you think so? Because arthroscopy takes over the diagnostic part much more conveniently.
What do you mean, the diagnostic?
Yeah, the diagnostic aspect, diagnosis through arthrocentesis is much more ubiquitous, much more confusing as through arthroscopy.
I'm looking at the patient reaction to the treatment. I'm looking at the pain. I'm looking at the patient well-being. I don't care about what type of synovitis and adhesion he has. It doesn't mean anything. I've done arthroscopy many times, and I realize it's much more harmful, many more complications, and I don't need it for the well-being of the patient. I'm sorry, you understand?
Yes, of course I do. And the last thing is, what are the complications in arthrocentesis that we can come across?
you know, a temporary facial paralysis of the, you know, frontal branch, or swelling or infection. But be honestly, if you do it correctly, you don't have complication.
Do you need to give antibiotic cover, madam? Do you need to give
antibiotic
cover?
I do. Okay. I give them.
And even in high inflammatory disorders like rheumatoid arthritis, when the patients are on immune suppressants, I think antibiotic cover would be mandatory, right?
I do give them, yes. But I'm very careful in cleaning the area, very.
Okay.
Okay.
Yeah. So, ma'am, there are many studies on the use of PRP and PRGF, especially in osteoarthritis, where they say the release of growth factors and other, you know, matrix proteins that are stimulated by these PRP, like fibrin, fibronectin, etc., might, you know, help in regeneration. Do you have anything to say on that?
Not much, because I feel that everything stays there for a short while and then it goes out.
Yeah.
So I inject sometimes steroids, you know, the bone.
Yeah.
I don't, but I cannot say, I didn't research this spot. It may be very good.
Yeah.
I don't know.
There are a few publications which say that, you know, they stimulate the proteoglycan matrix and, you know, also, you know, harbor a lot of cartilage and bone cells that help in regeneration osteoarthritis.
Yeah, okay. Okay, yeah. But I didn't feel I need it, but I may be wrong.
So, ma'am, finally, which category of patients do you think require an open procedure, you know, after failed arthrocentesis? So, what is your recommendation on open surgery?
That's a very good question, Dr.
Post arthrocentesis.
You know, that who stays with severe pain, severe limitation, after arthrocentesis. I don't go for arthroscopy myself.
So what surgery do you recommend? Do you go for a discectomy post in case an arthrocentesis?
This is another issue again.
Yeah.
This is another issue.
Yeah.
But I'm not afraid, because I can show you that I do complete. This is another topic. If you can read my paper from 217 on closed reduction for loss of vertical dimension.
Yeah.
And then we can talk about the surgical procedures. I'm not afraid of condylectomy.
Oh, okay.
So I'm not worried. You have good opening, good occlusion, easy. So if you need surgery, no problem, but you have to need it.
True.
But first of all, maybe if you want to look at this paper, and then we can discuss.
Surely, ma'am. Surely I'll look into it. I have not read that properly.
It's a paper of Pala and myself.
Okay. It's 2017 month.
I think, yes.
Okay.
So we can talk about this, and we can talk about the examination, and we can talk about condylar hyperplasia.
Condylar hyperplasia.
And we can talk, now we have a very interesting study on ankylosis, the gap arthroplasty.
Yeah.
Which we do like in India, just gap arthroplasty with very good, really, I'm very happy with the results. But we have the system, we have a like program for each patient, and it works very well.
Okay.
Nice.
Ma'am, any more questions from your side?
No, I think I'm more or less done for today's evening. I hope you had good time with us, Professor Nitzan.
Thank you very much.
Thank you, ma'am. Thank you for the wonderful insight. It was really learning experience, and we could clear a lot of the doubts.
Happy to. We can also always we can correspond, you know, with the email and WhatsApp and.
Correct. True, ma'am. True.
Okay.
Professor Nitzan, we would love to have you again on TK Live for condylar hyperplasia. I hope you'll.
Okay, so contact us, okay?
I would definitely stay in touch. Thank you so much, everyone, for this amazing evening with me. And this is the last session for this year, and now we will meet next year. Thank you so much, and hoping to see you all in AOMSI Indore a couple of months from now. Thank you.
Okay.
Yes.
Bye-bye.
Bye-bye.
Thank you, ma'am.
Good morning, good evening, and good night.
Wonderful to be with you.
Thank you. Thank you so much.
Thank you, ma'am. Thank you.
Namaste.
Bye-bye. יאללה, בואי, בואי לים. שלום.